progress.
Assalamu alaikum everyone. Sorry for the little delay. We will start our session now. Today we will cover the high yield SBA for the urology. So the first MCQ, the 16-year-old boy presented to ED with left testicular pain. The pain started suddenly about 3 hours ago. On examination, the scrotum is swollen and tender with blue dot sign. What do you think as a diagnosis? I think you have not read the scenario carefully. I will request everyone to read it again. On examination, the scrotum is swollen and tender, but there is blue dot sign. Yes, it's a it's a torsion of testicular appendix, or also known as a hydrated of Morgigni. Some of you are confusing it with testicular torsion. Remember, this blue dot sign. This is very specific for the testicular appendix torsion. Okay, and unlike testicular torsion on examination, you will also see that the testicle is freely mobile, and also the cremasteric reflex. This will also be present, unlike the testicular torsion, which it will be absent. But this blue dot sign, this is very specific for the testicular appendix torsion, not for the testicular torsion. So that's what confusing. Okay, 59-year-old male presented to ED with suprapubic pain. According to him, he last passed the urine 12 hours ago. Which of the following investigation is most useful in his case? Which of the following investigation? Let me see. Varian, please write your answers. Okay, what do you think? What are you suspecting in that patient? That will help you in getting to the right answer. And tell me what are you suspecting in that patient? No, BPH. Okay, BB. Prostatitis. Okay. He is pubic pain. He last passed the urine 12 hours ago. Usually, what do you think the patient is suffering of? Yes, it's acute urinary retention. Okay. Acute urinary retention, and the most useful investigation in that case will be to do the bladder scan immediately in the ED. Okay, in the ED, you can do the bladder scan, you can calculate the urine volume, and if that is equal to or more than 300 ml, then it is specific for the urinary retention, and you have to relieve that obstruction, pass the Foley's or suprapubic catheter if Foley's cannot be passed. And those who are saying there is prostate examination will not help you in that case. Yours, but BPH may be the cause of urinary tract obstruction, but in in short term, it will not help you in that patient. First, you have to relieve that obstruction, then later you can find out the causes of that obstruction. The first you have to relieve that obstruction. So that's why in that case, in that patient, first you have to do the bladder scan to confirm it is a urinary retention. And the volume of 300 ml or more than that, you will consider it as a urinary retention. So, a 23-year-old female presented to ED with dysuria and increased frequency of urination for the last 3 days. On examination, she had soft, non-tender lower abdomen. On urine routine examination, it is positive for leukocytes and nitrites. Which of the following antibiotics is most appropriate in her case? This is a lower UTI and lower UTI nitrofurantoin. Uncomplicated lower UTI, we have nitrofurantoin or trimethoprim is the first drug of choice. This 9-year-old male presented to ED complaining of 3 days of dysuria. He complains that he had poor stream of urine since last day, despite feeling that his bladder is full. He also complains that his perineum is quite tender. What do you think is the most likely diagnosis? Yes, is prostatitis good? Prostatitis patient may have a lower UTI symptoms like increased frequency of urination, dysuria, along with other symptoms like perineal pain or pain on defecation or backache. And on DRE, you will feel warm, boggy, and tender prostate. So these are some of the signs and symptoms of prostatitis, and that patient was suffering from prostatitis. So, a 23-year-old male presented to ED with swelling and pain of his glands. He tells you that it happened 2 days ago as he was unable to retract his foreskin. And swelling developed over the next few hours. He had delayed presentation to ED. What first-line reduction technique would you use? First, tell me what is the diagnosis and then tell me the management of this. So it's yes, it's okay. Yes, it's phimosis. So what will be your management? How will you manage this patient? Let's see identity technique. Now some of you are saying identity technique. It's not the first line. The first line reduction technique is not identity technique. It's second line. First is the manual reduction with the osmotic agents. Okay. So when the patient presents to you with the paraphimosis, first step is to manual reduction with the compression of Glenn penis and applying osmotic agent over it to reduce the edema and swelling. So it will help you to manually reduce the paraphimosis. So first step is to manually reduce it. Second step is the Dundee technique, in which we make multiple puncture wounds in the foreskin to reduce the swelling and reduce edema. And then third step is to refer the patient for surgical intervention. So Dundee technique is the second step, okay, not the first line. Okay, so 76-year-old male presented to ED complaining of sacrotal pain over the last 12 hours. He has a past medical history of type 2 diabetes and rheumatoid arthritis. On examination, he is febrile and tachycardic and has gross swelling of his scrotum and perineum, which is very tender to touch as well. What is the most likely diagnosis? What is the most likely diagnosis? Using impegliflozin. Even if the patient is not using impegliflozin as SGLT2, still has a risk of necrotizing infection for near gangrene. So how will you manage this patient? Suppose, what is the management of this patient? Will you manage this patient in ED or will you refer him? Yes, it's a surgical referral or the surgical debridement. So foreign gangrene is actually the necrotizing fasciitis of the perineal scrotal lesion and very high mortality. So we have to urgently refer the patient for the surgical debridement. 75-year-old may present to ED with 3-day history of left-sided testicular pain and swelling. On examination, scrotal erythema is noted and left testis is very tender. There is high suspicion of pediatric. What examination findings support this? What examination findings support your diagnosis? Brand sign negative or positive? Yes, brand sign is specific. Brand sign is specific for the pituitary morchitis. We usually elevate the testes, and if it relieves the pain, then we call it the positive brand sign. But remember, the negative brand sign does not, positive brand sign, sorry, does not exclude the testicular torsion. Okay. So 21-year-old male presented to ED with 4-hour history of severe testicular pain. He describes the onset of pain while sitting, and you suspect testicular torsion. Which of the following is the most appropriate first-line management for this patient? First-line management for the patient with testicular torsion. Yes, it's urgent surgical exploration and detorsion. And while waiting for the surgical exploration, we can try manual detorsion, but the first line appropriate management is always the surgical exploration. And also we can't refer the patient for the imaging if we have a high clinical suspicion of a testicular torsion. Then we cannot waste our time by sending the patient for imaging and delaying our surgical exploration. So again, the urgent ultrasound of test is also wrong option, and manual detorsion also not the right option. So immediately the patient should be referred for the surgical exploration. Imaging should be done in those cases which are equivocal, and our diagnosis we are not sure about our diagnosis. So in that cases, we may do ultrasound. Otherwise, if we have high suspicion, then we should not delay the surgical exploration and should be done immediately. And 76-year-old male presented to ED with a 12-hour history of being unable to avoid his bladder. An ultrasound scan is done which shows 700 ml of bladder volume. Foley's was passed, which provided much relief. Which of the following is not an appropriate investigation in this patient? And why is that? Why a posterior specific antigen? What is the reason behind? Yes, which of the following is not an appropriate investigation in this patient? RFTs now. RFTs we will do. Look for renal impairment. RFTs we will do for look for renal impairment, inert sound for any renal impairment, urine dipstick for hematuria, CBC for look for any infection. Prostate specific antigen acutely after the it can be falsely elevated actually after DRE or urethral catheterization. That's why we don't do it immediately, and we will defer it for about at least 2 weeks. and also in short term it will not help us in that case anyway. So that's why we will not in that patient prostate specific antigen is the not the appropriate investigation. Urine dipstick we will do. Okay, urine dipstick I said we will do to look for hematuria. Urine ultrasound, RFTs and electrolytes for look for any urine impairment. CBC look for infection. These are the appropriate investigation that we do in case of intention, but posterior specific antigen we don't do it. We delay this investigation for at least 2 weeks. A 19-year-old male presented to ED with 2-hour history of atraumatic left testicular pain. Examination, the left testis is tender, and you suspect testicular torsion, arrange an urological review. Which of the following is the risk factor for this condition? Is pelvic deformity in which the actually the tunica vaginalis attaches abnormally high on the spermatic cord, leading to the very mobile testis. Like in that case, you see this is normal one, and this is pelvic deformity. So it increases the risk of testicular torsion. Other risk factors for testicular torsion. Does anyone know other risk factors for that? As undescended testes and testicular malignancy, these are also some of the other risk factors. So 25-year-old male presented to ED with painful testicle. He returned from holiday 1 week ago. Examination, his scrotum is tender and swollen. No past medical history. You suspect epididymoarthritis. What treatment should be recommended to this patient? Yes, BB, ceftriaxone plus doxycycline. Yes, it's ceftriaxone, doxycycline. I will explain to you why. But first, solve this MCQ. A 67-year-old male presented to ED complaining of pain in scrotum. He has no past medical history. On examination, his left testis and scrotum is found to be tender and swollen. You suspect epididymoarthritis in that patient. And now, which of the following is best antibiotics for this patient? Let's see, C and A. So, see, Both of these patients had epididymoarthritis. Okay, this is a young male with a history of travel history, and now he has epididymoarthritis. So remember, in young patients, the epididymoarthritis mostly caused by sexually transmitted organisms like Neisseria gonorrhea and chlamydia. So our treatment is different in these age groups. Like ceftriaxone and doxycycline is a drug of choice. But in older patients like more than 35 years old and older patients, enteric organisms like gram-negative E. coli and Klebsiella, these are the organisms that mostly cause epididymoarthritis. So the drug of choice and antibiotics is different in these age group patients. It's mostly quinolones, ofloxacin, or ciprofloxacin. So that's why in that patient, this or a 69-year-old male, and the drug of choice would be ofloxacin, not iron ceftriaxone. A 24-year-old female presented to 24-year-old female presented to ED with a history of dysuria and flank pain. She has no significant medical history. On examination, she is febrile and tenderness noted in the right renal angle. Which of the following antibiotics is most appropriate in that patient? Yes, this patient has pyelonephritis. So what will be your drug of choice? It's not nitrofurantoin. It's nitrofurantoin is for lower UTI. Cefuroxime. Okay, Dr. Neil is saying cefuroxime, but IV cefuroxime. Will you give IV antibiotic to that patient? And someone is saying EIV comoxiclav. So still I don't have got the right answer. It's actually oral cefalexine. Remember, management of pyelonephritis is different from the lower UTI. And nitrofurantoin and trimethoprim, that are the first drug of choice in lower UTI. These are not in the pyelonephritis. Oral antibiotics or IV antibiotics, depending on the patient. Okay, but both are effective. Okay, equally effective. Oral antibiotics and IV antibiotics are equally effective, but remember, IV antibiotics should be used when oral can't be tolerated or patient is very systemically unwell. So in that patient, we use IV antibiotics. Otherwise, oral antibiotics, if patient can tolerate, then we give oral antibiotics. Oral antibiotic drug of choice are spalexine, comoxiclav, ciprofloxacin, emethicillin. These are the drug of choices. And okay, and IV antibiotics, same comoxiclav and cefuroxime and this third generation cephalosporins, ciprofloxacin. But there is no difference in treating the patient with pyelonephritis with oral IV antibiotics unless or until patient is not tolerating orally or systemically very unwell. So in that case, we will give IV antibiotics. So 23-year-old female presented to ED with 2-day history of fever, dysuria, and flank pain. Her observations are heart rate 110, BP 96, T respiratory 24, saturation 95% at room air. Temperature is 38.5. What antibiotic should be used when this patient. So yes, no, you're right. This patient has pyelonephritis and he is very systemically unstable. And she is in sepsis, so that's why we can't go with the oral antibiotics. We have to admit the patient and start IV antibiotics. And here, the most suitable option is the IV supervisine. A 56-year-old female with a past history of congestive heart failure present to ED with right side abdominal pain radiating to right groin. She describes it as coming in waves and severe intense pain. Urine routine examination showed 3+ blood. Her urine pregnancy test is negative. What is the first line of recommended analgesic in our case? This is the recommended analgesic diclofenac. Okay. Okay, let's see first choice. And this is what Joanna said. I miss kind of answer due to she has a high paracetamol. So yes, that's why I always say that first read the scenario carefully. Yes, nice. It's high paracetamol actually. So according to nice guideline, yes, you are very right that first line is always NSAIDs by any route, IVIM. But remember, if there is no contraindication to it, then the first line is your NSAIDs. And or if it is not effective, if you have given NSAID not effective, then the second line is your IV paracetamol. And if your IV paracetamol is contraindicated or not effective, then you go with the IV opioids. So in that patient, you see the patient has a renal colic. Yes, your first line will be NSAIDs if patient does not have a contraindication to it. Okay. So this patient has a contraindication to use of NSAIDs. That's why you will go with the second line, which is IV paracetamol. Otherwise, if that patient doesn't have any contraindication, then we will go with the diclofenac. And if IV paracetamol is not effective, then we will go with the IV morphine. So always read the careful scenario very carefully because there is small hints in the scenario that will help you in answering your questions. 54-year-old male presents to ED with priapism, which has been ongoing for 2 hours. He takes multiple medicines. Which are the following? Medicine is the likely cause for the priapism. Yes, is fluoxetine SSRI most commonly very notorious to cause priapism. There are multiple causes for it. Drugs, SSRIs, propranolol, alpha blockers, these are and drugs used for treatment of erectile dysfunction. These are some of common drugs to cause priapism. Sickle cell disease, any malignancies, spinal injuries, they also causes the one of the causes of the priapism. And how will you manage the patient with priapism? How will you manage the patient with priapism? Yes, after aspiration, what will you do? Yes, you will give the injection of naltrexone injection into the corpora cavernosum. First, you will aspirate the blood and then give analgesia. Okay, after giving analgesia, you will aspirate the blood from the corpora cavernosum, and after aspiration of blood, you will inject the cavernosum with the naltrexone. And if that does not resolve the priapism, then you have to refer the patient for surgical intervention. So in that, yes, according to antispasmodic, remember antispasmodic and renal or uretary colic are, according to NICE guidelines, are not recommended. Okay, and they do not provide any benefit to the patient. Someone said in that case, priapism, amitriptyline, no, it's not amitriptyline, it's the SSRIs. These are most notorious to cause priapism, not the TCS. So that was all about your urology SBAs. Any questions so far? Um, Treatment for prostatitis is quinolones, ciprofloxacin, ofloxacin for 46. We will give quinolones. Okay, I think it's for 2 weeks or 4 weeks. But duration I don't remember, but it's actually quinolones. Okay, and then you after the treatment with the 2 to 4 weeks, you will review the patient whether he is responding to not treatment or not. But the drug of choice is the quinolones because mostly the prostatitis is caused by the again like UTI caused by mostly a gram-negative organism, E. coli, and Klebsiella, these organisms. Suppose management priapism, first, as I said, aspiration of blood. Okay, you will pass the butterfly and aspirate the blood from the corpora cavernosum, and after the aspiration of blood, you will inject the phenylephrine, which will cause vasoconstriction of the blood vessels, and if that does not resolve, then you have to send refer the patient to surgery. Okay, that is the stepwise management. Mm. Any other question? Tomorrow topic, I will discuss with Dr. Khizer. I will let you know which we should do tomorrow, but it's not confirmed yet. I have to discuss with Dr. Khizer first, okay? Okay, thank you so much, everyone, for listening, and meet you in the next session. Thank you.